On behalf of the Apollo Center of Excellence in Critical Care, it's my pleasure to moderate this webinar on transportation of a critically ill patient, which, as we all know, can be a real challenge. And the most important thing is really to be prepared as a team to handle any kind of transport of a critically ill patient, whether it is inside the hospital or outside the hospital, between hospitals. So we have two excellent speakers today who are experienced critical care practitioners. We have Ms. Miki Ben Patel, who is a critical care nurse from Apollo Hospitals in Ahmedabad, who would be starting and addressing on how to really be prepared as a nurse and as a team member to transport critically ill patient. And subsequently, we will have Dr. Pratima, who is a senior consultant and coordinator for the Department of Critical Care at Apollo Specialty Hospitals in OMR, Chennai. She would address challenges with citing examples on how exactly to handle these situations. Without much more, let's start with the session with Ms. Patel. And if any of you have any questions that you would like to pose to the both the speakers, kindly type it in the chat section, and I will take it at the end of the session, at the end of both the sessions. Thank you so much. Over to you, Ms. Patel.
Namaste all. I am grateful and privileged to have this forum to present today's presentation. I would like to thank our Group Director of Nursing, Dr. Captain Usha Banerjee ma'am, Trupti ma'am, Manjunathan sir, Rupa sister, and my colleagues. A special thanks to Pinakin ma'am and Muthra ma'am who availed this opportunity. Let us begin today's clinical integration. Transfer of critically ill patient is dynamic and often precarious physiological state. Transfer potentiality expose them to additional harm and instability. While we are transferring the patient, it will expose the patient to additional harm and maybe it result the instability. So the goal of critical care transfer should be maintenance of high quality care while moving the patient to an appropriate location in expanding and in a good and safe manner. So the review of critical care transfer is to provide an overview of safe transfer practice and is not intended as how to guide. This content is completely taken. This content is completely taken from British Journal of Anesthesia. So here is the content, bottom of the slide. There are the types that shows the transfer of critically patient, how it is performed by healthcare professional using various platforms. The first and foremost is position on care pathway. The primary one, secondary one, and the tertiary one. It all depends on the patient's need. On the basis of the patient need, we are transferring the patient. We have to assess whether the patient requires primary need, secondary need, or on the wholesome needs of the tertiary care. The transfer platform are while we are transferring the patient from bed, road, or maybe use of air ambulances. The third one is urgency of care, which is emergency, urgent, or routine transfer. So we need to assess the transfer is urgent, emergency, or it is routine transfer from one department or one hospital to another hospital. The fourth one is level of care provided in the transit. This is the scale that designed by the British Journal of Anesthesia for rating school and which give the brief idea about the care we are providing during our transferring. The indication for transfer, it is all up to the clinical condition and the capacity of patient as well as the patient family member. Then the another type is distance duration of transfer, in which the first one is intra-hospital. That is the interdepartment transfer of the patient while we are shifting the patient from ICU to imaging department or any other department within the hospital. Then the inter-hospital, it is related to two hospital, referring hospital as well as accepting hospital. Mainly this kind of transfer we see in our hospital. Then there are the process to transfer the patient, which contain following steps. First is identify need to transfer a patient. So we need to identify the need of the patient while we are transferring the patient. Then agreement between referring and accepting senior clinicians. Both the clinicians should have complete communication while we are transferring the patient from the referring session to the accepting ones. The third is handover from critical care staff to transfer team. This is the important aspect while we are transferring the patient. The handover should be there from the critical care staff to the transfer team. So it can facilitate smoothing of the transfer. Then the fourth one is transfer between the care facilities. We should communicate to the both of the transfer facilities to facilitate the transfer easily. Then handover from transfer team to accepting team. It should be there while the transfer team drop the patient to the accepting hospital. So they have to give handover properly communication to the accepting team. Then return transfer team and equipment to base. The base is that the returning of the transfer team as well as the equipment which we send for the transferring of the patient. So it should be there while we are transferring the patient. There are several risks related to transfer while we reported and split into three categories. The first one is technical. In the technical, we can say that there is a patient as well as equipment related risk. The patient related risks are discussed later, as well as equipment related risks are discussed later. The second is non-technical. It is related to crew resource management. Crew resource management is like while we are sending the transferring person to another hospital, so they need some resources. So it is kind of non-technical risk. Then the organizational related risk. The setting of the training and the competency. In training and competency, setting the standards for the transfer. In the setting of the standards, there is two, training and competency. So we need to train the staff, those who are transferring the patient. We should deploy them in a particular group, and we have to give particular training to that staff so they can easily transfer the patient, and it shows the competency of staff as well. Then checklist and apps for the easily and smooth transfer. We have a particular checklist which contain the following. The first is airway. So before transferring the patient, we should assess the airway. If it is in the doubt, so we need to intubate the patient, and we need to take the patient on ventilator, and we have to provide proper support to the patient. As well as we need to assess the cervical spine control also in the airway. Then second is the breathing. The portable ventilator setting should be there to facilitate the easy breathing to the patient. Then check ABG while we are taking the patient to the portable ventilator. After 50 minutes, we need to check ABG. Then back valve ventilation should be there with us while we are transferring the patient. As well as the suction should be there. Then adequate sedation, analgesia, and relaxation should be there. Then adequate O2 reservoir and insert the chest drain if it is required. The third one is the circulation. Then stable the circulation with the good access. Control external bleeding if any bleeding is there. So we need to control that. Then invasive BP and CVP care. In inotropes, we need to bring. Then pumps and batteries, well operated pump should be there. Urinary catheter should be taken care. The third one is disability. So we need to assess the Glasgow coma scale of patient. According to that, we need to maintain the scale. Also, we need to check the pupillary sign of the patient, whether it is reactive or non-reactive. Then naso and orogastric tube should be taken care. The important one is exposure. We need to assess the patient while we are transferring the patient from transferred facility to the accepting facility, which is hypothermia. So we need to minimize the exposure of heat, so we can prevent the temperature loss. And we need to taken care of splint long ones while we are transferring the patient with multiple trauma. Then the last one is forgotten, that is all notes should be completed, inform receiving unit, inform relatives, taken contact number of relative as well as the receiving facility, then take warm clothing, mobile phone, food, credit card, money for the team, and plan for the return journey. The transfer process, which contain more than 5 components, which is first one is who. It is imperative patients are transferred for the appropriate clinical reasons with high demand for finite services. It may be necessary to transfer patient who no longer need such specialist care to enable a more appropriate admission. So we are going to transfer the who. A patient should be there while we are transferring the patient. So the answer of who is the patient with whom we are transferring. The choice of transfer team will determine the scope of the transfer. So appropriate trained staff should be there, those who are having the competency for transfer, so we can transfer the patient under distant supervision. Then when the process of transferring a patient from referral to handover can often take longer than anticipated. How we are transferring? So as I mentioned, airway, breathing, circulation, disability, exposure, packaging, documentation, proper communication channel, and handover should be there. With what? We need to take in care of emergency drugs like adrenaline, non-adrenaline, vasopressin, and all other drugs, sedatives, analgesics. Then equipment, well-functioned equipment should be there. If we are preferring the road, then the all facilities should be checked, and if it is appropriated, then we can begin the transfer. And while we are transferring the patient by air, so all should be maintained. These all are the essential equipments that we require for the patient while we are transferring the patient from one facility to another facilities. The most important thing while we are transferring the patient is monitoring during the transport. So all critically ill patients undergoing transport receive the same level of basic physiological monitoring during transport as well as they had in the ICU. So it includes the ECG, pulse, blood pressure, respiratory rate, and oxygen saturation monitoring. All battery operated equipment should be fully charged and capable of functioning for the duration of transport. While we are carrying all battery operated equipment, so we need to take standby equipment and other equipments with us while in the case of broken down and any other technical issue. There are some adverse effects while we are transferring the patient, in which there is 2 types. Mishaps related to instrument should be there, and patient related effects. The first in the mishaps related to instrument. So what kind of adverse effect happened while we are transferring the patient from one area to another area related to instrument is one, lead disconnection. It is going to be happen, loss of battery power, loss of IV access, accidental extubation is there, occlusion of ET tube. Maybe sometime we can see that the occlusion partially and closely occlusion of ET tube be noticed. Then exhaustion of O2 supply. There are limited O2 supply we bring with the patient, and there is a complication related to O2 supply. So we need to bring the another alternatives with O2 cylinder or anything else that carries enough amount of O2 with us. Then patient related effects. Mainly this kind of effect, we can see that worsening of hypotension while we are transferring patient. As I see in my area, that worsening of hypotension may be persistently hypotension is increasing while transferring the patient and sometimes it is a worsening of hypertension C because of battery disconnection and other issues related inotropes. So it may be there. Then hypoxemia and arrhythmias is there. Then care of transport team is also important part while we are transferring the patient from one department to another. The personal protective equipment organization should provide the personal protective equipment while while the staff is shifting patient from one area to another area. If patient is suffering from contagious disease, so it should be there. Then insurance should be there for staff as well as the medical indemnity for the patient. Patient, it is the side from who is the main consultant main consultant of the patient, so it can cover the insurance of staff and as well as the patient. While some mishaps in the mishaps during the transfer. The dedication of the staff, the dedicated transfer teams may reduce the complication during transfer and lessen the staff pressure at referring hospital. As I mentioned, the transfer of critically ill patient require lots of training and the communication skill as well as the competency of staff. So it can reduce the mishaps related to equipment as well as mishap related to patient, and also it reduces the burden of the referring hospital, those who are receiving the patient, and it facilitates the smoothing of transfer process. Documentation is most important thing while we are transferring patient from one area to another area. The clinical status before, during and after transfer. As I experienced that we prepared one clinical summary for the patient before transferring the patient. The all physiological and vital parameters we mentioned in the sheet. Ongoing in the transfer, we are monitoring all the parameters of the patient and document for legal purpose, as well as after transferring the patient, the proper communication and handover of the documentation should be there. Then second one is the patient condition. The patient condition should be monitored during the transfer and it should be documented if it is worsening or it is improving while transferring. The proper handing over between the referring, transfer and the receiving doctor. So while we are transferring the patient from one area to another, so we need to give the complete handover to the transferring team, and the transferring team should give complete handover to the receiving doctor. In the end, evaluate process of transfer for quality improvement. So while we are doing this process, the entire process should be evaluated by experts, and it can result in for good quality improvement. This content is completely taken from the British Journal of Anesthesia. You can look at the bottom of the slide. Here is the reference. Thank you.
Thank you, Mickey. That was really good outline of what needs to be done to be prepared to transport a critically ill patient. As you appropriately stressed, it's important to have competent professionals being trained, being prepared, having the appropriate equipment, and more importantly, communicating with each other appropriately. And I think you stressed on all the aspects very appropriately. The one thing I wanted to specifically mention here is every member of the team is absolutely important during the transport of the critically ill. And if anybody had any concerns on the safety during transport, they need to speak up. And that's where, like transporting the patient safely is much more important than just rushing the whole process and having a problem during the transit, which can be a real issue. A couple of other things that I wanted to mention based on your talk was mainly about the handovers. And you mentioned about the multiple handovers that happen during the transport of the critically ill. And I think several of us may remember, at least at my age, who have played a game where we sit around and then we communicate something in the ears of someone, and then it passes on to everybody else and comes back to you. And you will be surprised at how distorted the information could be. Like when it comes back to you, the same information that you say, when it goes through multiple people, can be completely distorted, which is where it is essential to document and pass on the handing over to each other. And you mentioned about checklist, and several of us would have probably read the book on checklist manifesto by Atul Gawande, where he stresses on the importance of having checklists in healthcare. And probably checklists have saved more lives than several fancy equipments that we have in critical care. So with that, we will move on to our next talk by Dr. Pratima Kamal, who's, as I said, is a senior consultant and the coordinator for the Department of Critical Care at Apollo Specialty Hospitals in OMR. Before we move on to that talk, I just one housekeeping announcement that I wanted to make. I have opened the chat section where you could please type your questions if you have any. But I do notice that there are some institutions where several of you are sitting in a room. So if you want to pass on those questions to somebody to enter in the chat section, that would be fine. Or we could probably at the end try and see if we can allow you to directly communicate and ask the question. Over to you, Dr. Pratima.
Thank you so much, sir. I hope I am visible and audible well. Thank you for the introduction. I'm Dr. Pratima. I'm a critical care consultant. Sir did introduce me well. Thank you so much. And thank you, Apollo team, for this opportunity to talk about a well-established and well-visited topic of transfer of critically ill patient. So without much delay, I would want to just go ahead with my talk. So transfer of a critically ill, why is it very important? Why do we worry so much? As Miki Patel has already told us and has talked in detail about how and what and all we have to do to prepare a patient for transfer. I'm on the right base. So this is how a patient looks in a critically ill situation in critical care unit. Suddenly somebody from the family or referring physician might want to again take the patient in, and they would suddenly ask for a requisition comes in for a transfer of a patient. So the transfer team as a group of set of people, as Miki Patel rightly mentioned, there will be a dedicated transfer group who goes and visits this patient and look after the patient. There is a lot of things to plan before doing a transfer, and that should be beneficial to the patient as well. So first is the assessment, planning, and there are a lot of steps. And why do we have to worry about, and how do we have to transfer this patient, and what should be done in the best care of the patient is what we are going to discuss in the next few minutes. So steps of transfer, Miki Patel has already mentioned in detail. I'll just go through about this. So first, identify need of a need to transfer a patient. Is it really needed? Should we take the patient to the place, or should that a procedure or any investigation can be done at the bedside? Or what is the need for the transfer is the first and primary thing we have to identify as a transfer team. And agreement between the referring and the accepting senior physicians. So the thing is, there should be a good agreement between the outgoing and the incoming place. Whoever is receiving the patient should know about the patient. They shouldn't be taken by surprise. And whoever is referring needs to talk to them, give a good handover even before shifting the patient. Just an overview of what to expect from the situation of the patient currently, because they would have seen at a different phase, and now the patient would have had different changes in their hemodynamics or their stability issues or some support management. So it is always better to for them to talk to each other before even starting the transfer, and handover from critical care staff to the transfer team. So as a transfer team, we need to talk to the critical care staff who has recently seen the patient, what was the morning rounds about, and what were the investigations which was done recently, any change, any trend in change, because the requisition would have come the day previous. But when we look at the patient, that things would have changed since then. So it's better to have a good handover from the critical care staff to the transfer team. And the transfer between the care facilities should be planned accordingly. And once the transfer team takes the patient to the accepting team, the handover should be exactly and appropriately handed over including the events or plus or minus what happened during the transfer should be detailed to the accepting team, and return of the transfer team and equipment to the base. So this is also very important because the transfer team is in charge of whatever equipment they used and what they had taken there and what they are going to disconnect from the patient and bring back. So these are the 6 steps of transfer. It is very easy to put everything in a slide, but this takes a lot of planning and execution to happen. So ACCEPT is one of the acronym which actually is the whole of what Ms. Miki Patel had detailed to us. So assessment of the patient, control whatever is happening, control of the situation, good communication about the takeover, handover, etc. Evaluation, and preparing and packaging, how we are going to check and how we are going to take the instruments, give a good package to the accepting team, and how do we plan the transport. This is in short the acronym we can just make as ACCEPT. So why do we worry? Why do we have to worry about shifting these patients? It is like patients are already critical. What would happen? So there are these patients having a lot of equipments and machines connected to them, lot of tubes connected to them, which needs to be transported among the patients. It's not only the equipment we are going to push. It is not only the patient we are going to push. It is along with the equipment. We do not want any disturbance in what the patient is already going through. At least we can make them better, not worse. So they are critically ill, and there is increased risk of instability during the transfer. And they have some acute pathology going, and that's the dynamics of their situation is continuously changing. So we need to worry. When we take over, the dynamics might be different. During the transfer, we should know what to expect. So that is a primary and primemost worry about the transfer of the patient. And current drug therapy, they are on different infusions, and they might be on different therapies like renal replacement therapy. They might be on a continuous renal replacement therapy. We are going to just take them off the therapy and put them on a road or air and take them off to some other place. Will they tolerate such interruption in the therapies is another thing. And reduced ability to compensate. Okay, what happens? We are going to stop it for some time. That's what we are going to think. Are we going to provide the same type of support during the transfer? Because if we have any tilt or any off the edge management, and the patient will not be able to compensate, and anything unexpected can happen, and the situation will be worse. And we are not in a controlled environment while during the transfer. It is very difficult to re-intubate or place lines during the transfer. So what are the challenges? So as I said, we'll go through each separately. So we will find more discussion. So airway related and pulmonary complications. So these are the challenges which are like broken into small parts, so that we have to address each one of them during and particularly before the transfer. How are we going to expect? What are we going to expect, and how are we going to troubleshoot? So airway related emergencies, pulmonary complications, hemodynamic alterations. There can be nosocomial infections, exacerbation of whatever existing injury in trauma patients, and interruption of therapies, acid-base disorder and glycemic control, equipment and personal challenges, and unexpected emergent situations. So this is the whole game plan. So critically ill patient, we have decided to move the patient, and there can be anything happening from a minor adverse effect to a major adverse effect happening through the transfer. So till to the procedure or other ICU, it's going to be a full challenge facing game. So airway related and pulmonary complications, what can we expect? There can be pneumothorax and atelectasis, and there are many incidences where DVT happens, deep vein thrombosis happens during the transfer. If it is a very long transfer, patient is not moving, the patient cannot be put into all these sequential compression devices. There can be sudden pulmonary embolism during the transfer when we mobilize the patient. And there can be dislodgement of the endotracheal tube causing accidental extubations. That is almost reported as 0.4%. There can be desaturation. There can be some kink in the tubing when we just bundle up everything in one trolley. and oxygen saturation is as common as 8.8%, and the incidence involving airway related equipment, it is 17.6%. So anything can happen. The equipment might have sudden issues. There can be kinks of tubes, dislodgement, and as such patient might have sudden pulmonary edema. There can be some changing dynamics in during the transfer. So we must know how to troubleshoot each one of them, and we must know what can we expect in which patient. And hemodynamics, there can be significant hypotension and sudden cardiac arrest. This can happen just because the tube of the infusion might get kinked, and it can be getting dislodged, or there can be any leak in the vasopressor support. So nosocomial infections. So nosocomial infections, again, we can see that we cannot maintain the exact sterility during the shift. There can be contamination of the lines and tubes. So one thing what we can do better is clean up, dirty down technique. So this helps really. This is like all the clean things like ET tube, infusion pumps, syringe pumps, whatever we are giving as a clean IV, everything should be on the upper side of the patient, and the catheter, any fecal management system, vac dressing, which is just wound soakage, bandage, everything can be arranged in the down, like below the patient. So clean up, dirty down gives a good delineation between the clean and dirty things, so that they don't touch each other and get contaminated. So that can help better to avoid nosocomial infections. So in case of trauma patients, or when the patient gets transported from one place to the other, the patient can be having a spinal injury, and there can be a traumatic brain injury or other orthopedic injuries like fractures and other injuries which need a very good splinting, because during the transport there can be a lot of movement causing distraction of all these injuries. There can be worsening or even exacerbation, because when we had just checked at the point of start of the transfer, the neurology might be better, and once the patient reaches the accepting team checks, and they find there can be an exacerbation and worsening of the neurological status of the patient. So we need to be very sure that there is minimal movement for a traumatic patient. We need to go through each and every injury and make sure we have use a proper gear. The head should be in a proper gear, properly immobilized, with the neck should be immobilized with a Philadelphia collar. There should be proper splinting of the fractures. So all these are very, very important. Might look very trivial, but it is going to make a big difference during the transfer. So when we have really packed up very well, the minimal unexpected changes would be there. And even if it happens, we would know what how to react and what else to do to troubleshoot. Then comes the interruption of therapies. As I already mentioned, there can be like patient can be on insulin infusion, which can be interrupted. If it is a long transfer, we cannot transfer. And there can be acid-base disorders, because ventilation can be causing the number of respiratory movements, or the respiratory rate can be not set as much as that in the ICU. So that can cause increased carbon dioxide retention. There can be interruption of dialysis or CRRT, causing the acid to go up, and acidemia worsens. There can be interruption of vac therapy for the wound, so that there will be a lot of soakage of the dressing. So these are things which we need to think, and we need to do some management or some adjustment till we enter the place of the accepting team. So there can be other unexpected events which we cannot be prepared, but we must always expect the unexpected event situations also, like inappropriate weather, equipment failure, power failure, vehicle breakdown. So what as a transfer team should sit and usually practice, or every time they see a patient for transfer, on the earliest route, the patient through a very safe place. It shouldn't be any shortcuts, so that if the vehicle breakdown happens, there won't be much people to take care and ask for help. And if it is going to be a very highly traffic timing, delay the transfer. So and weather conditions should always be talked and decided. And in case of equipment and power failure, we must have a plan B. And somewhere the route has nearest hospitals, or we must know where can we get more help in case And it always helps if there is a presence of appropriate trained personnel. It is always better to take at least one senior person if the patient is very, very sick. And there should be properly functioning equipment. It should be tested and retested. There should be some equipment for a backup always, which is properly working. There can be, if the equipment is very important, like a transport ventilator, always it's better to have one more if the transport is going to take a long time. And there should be adequate documentation. Each person should know what they are going to do. And along with the documentation, assigning of roles are very important, because each person should take care of a particular task, like equipment, oxygen cylinder availability, or oxygen, how much oxygen is there in the cylinder, can it be lasting till the area, till we reach the accepting team's place, and pertinent checklist should be there. So each assigned roles, they will take care of their own territory, and if needed, they might be knowing how to tackle the situation, get help, and there should be a lot of helpline numbers which they can use, and it should be available in the transport vehicle. So, okay, these are things which we do during the transfer, we plan, and how are we going to take the patient? How do we decide on which mode we are going to transfer the patient? Is it going to be a land mode, or is it going to be air ambulance, or is it going to be a transfer with a fixed wing craft? So all these three are different, and we know that the patient, if the transfer is going to take more than 10 miles, then we need to consider air travel. But every type of transport, every mode of transport has its own disadvantages and advantages. Okay, so about helicopter transfer, it is air ambulance, which we have seen. It looks like this. There can be a very compact space with a patient space with a lot of available equipments and suction, oxygen cylinder availability, and pipeline also is there. So we can see that there are oxygen cylinders there attached to the even the door of the vehicle. So this is how it looks like. It looks very fancy, and patient can be transported with this also. And to know about this more, there can be very important 3 points which we need to know in an overview. So altitude, it can go up to only 1,000 feet. More than that, this cannot travel. And what we have to I understand about this is the cabin pressure cannot be adjusted in a helicopter. So any patient who just needs to go more than 10 miles, but cannot go a very high altitude, if the patient has a pneumothorax, or if the patient has any air-filled cavities, any impending perforation, who needs to go immediately to a nearby hospital for an emergency surgery, nearby I meant like more than 10 miles. So they can be shifted with this helicopter. And one more advantage is that there can be a helipad used. So the terrace of the hospital can be used as a helipad if the hospital is big enough. So it doesn't need any place for like an airport to be just landing. So it can be the takeoff and landing is very easy with the helicopter. And fixed wing aircraft, this is how it looks, and patients can be transported in this. And the main thing is altitude. It can go to higher altitudes like 7,000 to 9,000 feet. If there are any air-filled cavities and the patients have issues with air-filled cavities, which can have sudden increase in the volume, which we'll be discussing a little while later, we cannot use this fixed wing craft. So what we have to do is we have to prefer a transport by a helicopter if it is more than 10 miles and it's very distant. But the advantage is a cabin can be pressurized to the ground level. So if at all the cabin's pressure is depressurized, they won't feel the change in the altitude. So that is one good point. And the landing is a little bit difficult. So they have to land in a nearby airport, and land transfer has to be as an adjuvant from the airport to the respective hospital. So there will be two ships in transfer. So concern during air transfer, what should we have in mind is the low atmospheric pressure, which causes the hypoxia, and the FiO2 requirement goes up. So we need to make sure that we are increasing the oxygen flow and monitoring the saturation. Gas expansion, when the altitude increases, the gas expands in closed cavities. So there is also an issue of gas expansion, and family and patient anxiety is there when suddenly a sick patient is on a stretcher and flying in a helicopter. That definitely increases the anxiety. Movement related complications, it's not it's going to be a little bumpy, right? And it is not having any low movements. It is like it's going to be jerky. Noise and difficulty in communication is one more thing. With a helicopter, there will be a lot of noise, and the patient's communication or with the medical team is going to be a little difficult. So volume of gas in enclosed spaces, it increases as the atmospheric pressure drops. It is one huge issue, and we have to be making sure that the patient has a pneumothorax. If the patient has a pneumothorax, it has to be vented, and vented chest drain should be inserted prior to the air transfer. So we must always have in mind during assessment of the transfer, we need to make sure that we are venting off any air in closed spaces. And any patient with a bowel obstruction or a recent bowel surgery where we expect air to be in the bowel, which requires anastomosis, and if it is possible, it is better to be flown at a lower altitude. If we go at a higher altitude, there will be more expansion of gas. And winged aircraft we can use when we can adjust the pressure in the cabin to a sea level or a lesser altitude. Or whatever it is, if we have a very serious concern about this volume of gas everywhere, if it is a trauma patient, polytrauma patient, then it's better to consider land transfer. The more, the better. So land transfer also comes with a lot of its own goods and bads. So when a patient travels, it is not a very good experience lying like this in an ambulance. So it is not the usual travel how we do. So the acceleration definitely has an issue, and deceleration also causes an issue. So there will be an inertial force acting opposite to the force of acceleration or deceleration. So what are the effects of acceleration? There can be a decreased venous return. So the blood moves towards the feet of the patient, causing decreased cardiac output and decreased venous return to the heart. So there can be a hypotension. If there are sudden accelerations, there can be a decreased cerebral perfusion, and the cerebral injuries can worsen. So TBA patient, if the ambulance is going very fast, sudden acceleration, deceleration. So what should be kept in mind is the maintaining of a particular speed. They shouldn't be too fast, too slow. They need to be at a proper speed, and make sure there is a low traffic while they travel. And effects of deceleration, of course, cardiac failure, because the blood is now moving towards the heart. So we need to be making sure that the ICP is not raised, and there is a lot of risk of aspiration. So sudden jerky movements of acceleration, deceleration is going to create a lot of impact. So other issues is the temperature. In land travel, it is not very possible to change the temperature outside and inside. So as early as possible, we have to shift the patient to the recipient hospital. And duration for a long time, the patient is going to be lying the same position. So the pressure point should be padded well. There can be not much change in the position. So pressure ulcers are common. We need to make sure the patient, when we put on the straps, it is not irritating the skin and causing more pressure ulcers. And limited space. Imagine intubating or placing IV line during a movement of an ambulance. It is going to be very difficult. So if there are tubes and lines, it is better to fix it properly even before the transfer. So everything has its pros and cons, so positives and negatives. So land, ambulance, helicopter, and fixed wing aircraft. So positives is land ambulance, as we know, is very familiar, and there will be, it's not very expensive, rapid mobilization is there, and it is not affected by any severe, so like normal weather conditions, and easier patient monitoring. And even if we want to stop in between and get help, we can do that. So those are the positives, but it is slower, and it is affected by traffic, and it is better suited for only shorter distances, as I mentioned before, and unable to access patients in some locations when there is some trekking happens and patient has any injury and there is any hospital on the mountain, hilly areas, it is very difficult for the land transfer to pick up and drop patients. In helicopter, it is good to transfer patients into such situations like hilly areas and other things where altitude is high, and no need for land transfer because helipad can be used and directly we can transfer the patient into the hospital. But it is costly, and it cannot be flown into a very higher altitude and very limited space, and cabin pressure cannot be unpressurized. So winged aircraft for long journeys we can use it when road access is very difficult, and the negative point of helicopter, but the positive point of fixed wing craft is they are able to pressurize the cabin, and it is costly. Definitely it is the costliest transfer, and it can be only done by more trained people. It requires more and more training. It is not by the usual paramedics. They need special training for going in the fixed wing aircraft. So these are the positives and negatives. There are a lot of things which we need to give a lot of thoughts while transferring the patient. So decide always stable patient, yes. Then the destination determination, if it is less than 10 miles or weather is okay, then ground transfer. Then we have to contact the receiving physician and nurse. We can talk to them. If the patient is not stable, just stabilize the patient. If can be stabilized, it's good, and we can shift the patient through air transport. If it is like more than 10 miles and it is going to be okay whether we can do it. So always better to talk to the receiving team. So I know we have talked about a lot of things, but to put everything in one shell and summarize, we can just talk about a few points which we need to think first and foremost when we hear the word transfer. So benefits of intra-hospital transfer or intra-hospital transfer must outweigh the risk. So we have to just think about first the benefits. If benefits are good and risks are very low, it is okay. We have to decide. But decide on the transfer. But if the risks are very high with very minimal benefits, better to leave the patient as where they are. So a triage-like process should be done. It is, as I told, optimize the risk-benefit ratio for each intra-hospital or inter-hospital transfer. So the transfer team should sit with the critical care team and discuss about pros and cons and decide on with a proper plan. So no patient should be transported if it is unlikely to alter care. Is it really required is the first question. What is the aim of transferring the patient? Just for the sake of transfer, we shouldn't be doing the transfer if it is going to be deleterious to the patient. And as I told, when they decide, there should be checklist, there should be presence of specially trained personnel, and usually the senior medical officer of the transfer team should decide on the way how to the mode of transfer and whether to transfer the patient or not. Transfers may be very time consuming for the nurses, and see, there is a lot of team effort and specific knowledge brainstorming is going to occur when there is each transfer is planned. So it's better to always think twice about whether we can do a point of care alternative. Can the investigation like ultrasound, can the patient have a bedside ultrasound or a Doppler or can X-ray instead of shifting the patient for each of the transfer? And if it is going to be inside the hospital, then we have to just plan, like go get the patient transferred, go to each unit, finish the transfer, finish all the investigations and come back to the ICU at one go, then moving up and down. And if it is going to be an inter-hospital transfer, we have to give a lot of even more brainstorming. We have to call the transfer team, sit with them, discuss, is it really needed? Should we do it? Is it going to benefit the patient? What are the things which needs to be addressed? Okay, if it is really needed, what are we going to do? Aim. What is the aim of the transfer? And will the results have clinical consequences? And always better to document, talk with the family, of course, and talk about the risk in transportation. They must be well informed and they should consent properly. All the documents should be, all the consent should be documented properly. And patient assessment, if the consent is done, then we have to again check the patient. If the patient is stable enough, is it the right point in time? What are we doing? Are we going to benefit the patient or cause more harm? Then finally, with everything together, decide if expected benefits will likely outweigh the risk. Then if everything sets and every box is ticked in this, then we can prepare for the transfer. once we decide we are going to transport. Then again, is the patient stable enough, then we have to look at the ventilation, circulation, neurology, trauma. What are we going to look at? What are the tubes and what are the machines we need to carry? And the entire checklist should be observed and ticked off. So thank you. I think I have just given a very good overview so that if there are any questions, you can just put in the chat box or ask.
Thank you again. Very lucid presentation, clearly reflecting the experiences you've had, which takes me to the first question. One of the participants has asked whether we could share any experience of transferring a critically ill patient when you had an unexpected event.
Actually, we had a lot of small unexpected, thankfully nothing very serious, but we had definitely had some experience with the sudden dislodging of the tube. Actually, they had just put in the ET tube. When they wanted to cut it off, they missed the piece of the connection between the ET tube and the vein. So we couldn't ventilate the patient. So we had to move to a nearby unit because the patient didn't go out of the hospital. So it thankfully recovered. And we had to change that, cut off a new ET tube and fix that connector. So even the small things matter. That's how we make sure that which can be unexpected also. So we moved to the nearest place, like when the CT scan department was near the emergency room. So we could shift the patient there, get a new ET tube, cut it and get a connection and replace it. But we got a lesson from that, because if we had taken the patient out of the hospital in this way, if that ET tube had been damaged or that the small connection is lost, we cannot ventilate. So that is how we do it. And one more thing is, when the oxygen, there are instances when the cylinder shows full supply and suddenly it gets off. So we have to always have an ambu bag there, because it is self-inflating. With the veins, we usually do, we cannot ventilate when we do not have an oxygen source. So that those were the two main things which I had as an experience personally.
Yeah, I mean, I think that's a very important point. There was a time when we all moved towards vein circuit for everything. And, here is a situation where it wouldn't have helped you really. And, you need a self-inflating bag. And that's where, having an ambu bag would make all the difference. So, in fact, subsequently, all our emergency kits were, made to have a ambu bag rather than just a vein circuit. And thanks for sharing that. Miki, do you have any event or incident that you would like to share? Anything that you faced during transport of a critically ill and a lesson that you learned from it? Yeah, you're unmuted now.
As such, no experience I had throughout the 2 years of experience. But once I remember, I shifted the patient for the CT scan, and the patient is on the INET of support, and the battery coverage is not proper. So we urgently require battery for INET of support. So I got lesson from that always there is a standby battery or the standby syringe pump with us, so we can easily manage the situation.
Yeah, thank you. I'll briefly share a couple of situations that I've had when I was a trainee many years back. One was a nightmare, and the other was a very amusing situation that we all ended up with. The first one was actually a patient who was in the ICU, getting ready to be transported out for a procedure. Okay, and the nurse and the respiratory therapist called me and said that there was a cuff leak, and they said, "Can we change the tube before sending the patient for the procedure?" And I thought, okay, I mean, like it's a cuff leak, we could probably quickly change the tube and then send for the procedure. And we had a tube exchanger, and I put the tube exchanger in, removed the old tube, and I could not place another tube. Okay, so the next ET tube would not go in. And at that time, what also happened was, like I said, okay, I need to intubate. So I was putting a laryngoscope in. And the next thing I saw was the patient had severe subcutaneous emphysema in the neck, all over the face, and in the, in the chest area, very, very rapidly spreading subcutaneous emphysema. clearly reflecting that there must have been some kind of a tear in the airway. That's probably how quickly that could happen. And I could not put a tube in, and I had to call for assistance and got a tube. Um, in a way, it's a lesson that thankfully this was done in the ICU, where it is a monitored environment, where like others were available to help, and we could change the tube. In a way, I also thought if the patient was going to the operating room, and if they had in a slightly more controlled situation, like if they had done it, maybe this wouldn't have happened. So I don't know the answer to this, whether I should have really done it at that time. But doing such changes in a monitored environment to safely transport a patient is absolutely essential. Whether you communicate with the team receiving in the operating room, so that you tell them this is a problem, would you be able to take care of it there, and accompany the patient to the operating room. Or if you are going to change it, obviously do it within the ICU where you are monitoring the patient. The other one was kind of very amusing. This was a young person who was admitted with a suspected overdose. He was somebody who was using narcotics. They had given him some Narcan, which did not really, naloxone, which really did not help. So he was unresponsive and he was intubated. And after about 2 hours, he was not on any sedation, did not require any sedation. We didn't know what he had consumed. After about a couple of hours, like he was ready to be transported for a CT scan. And he really didn't need any sedation until then. We had everything ready. We took him into the elevator. And the first thing we knew, as soon as the elevator closed, this guy just sits up, awake, pulls the tube, and says, "What are you all doing to me?" Okay, so really, I mean, here was a person who was unresponsive. You're prepared, you're moving him, and completely unexpected, he wakes up, whatever it was due to maybe the effect of the drugs he had taken and worn off. And we could not even sedate him or do anything. We literally had to bring him back to the ICU. And he did fine after the extubation. There was no issues. But these things can happen, like the patient behavior can change, the patient can get agitated, can get so be prepared for any of those while you are transporting the patient. There are a couple of other questions. One was actually a couple of them have asked about medico-legal aspects while you are transferring the patient. Dr. Pratima, would you like to take that?
Yes, sir. Actually, it is like any other procedure because it has its own risk, and we are going to a uncontrolled situation. It is not a situation in which we can control everything, and that should be properly told to the patient's family. They need to be taking part in the discussion once we have decided, and we must ask them. We must let them ask questions. They should have a lot of doubts, and we need to address everything on only one paper and getting a sign. So because it is like we are putting the patient into a risk because we are transferring. So it is our responsibility to make sure the family is also well informed, and even the patient. If the patient is conscious enough, we have to talk to the patient and get his consent also personally.
Yeah, so obtaining a consent, educating the family on the risks of transport is absolutely essential. And it's like any other procedure. So theoretically, like, can there be legal issues? Yes. And a lot of institutions also favor having a family member with the healthcare personnel during even intra-hospital transport. So when you move the patient even within the hospital for a procedure, a lot of the times we do ensure that there's a family member present so that they are seeing that everything is transparent. You're doing your best, you're monitoring the patient, you're moving. Despite that, if something happens and they're there to, of course, they could be really like significantly upset when something untoward happens, but it's good to have them around when anything such happens. There's a question on how do you monitor the patient when in transit? And is the data available later for study purposes? Obviously, this is from our Chief Medical Informatics Officer, who probably is going to see how such data can be available at all times so that you can go back and look and see what happened, what could have been done, how different could we have addressed. Go ahead. I mean, the question was, how do you monitor the patient when in transit? Is that data available later for the study purposes? Pratima?
Yes, sir. There are a lot of things which we need to address. But when I For the sake of this talk, I went through all the evidences, and there are pretty much evidences which are actually given by the transfer teams. And as I have quoted a little bit of evidence in my talk, there are percentage of times when the monitors got disconnected. They were in no clue when there is. We don't know whether there is the ECG was there, but the pulse oximeter was not working. And there are case series in which there was pulseless electrical activity suddenly happening, and there was dislodgement of infusion pumps and disconnections in the tubings. So a lot of evidence are seen. It is like it is given in a lot of case evidences, which is put up in well systematic reviews and meta-analysis also. It is very surprising, but I will go through all the evidence. And monitoring can happen with the machines which have a battery backup. We can definitely monitor. We have specialized equipments to monitor during the transit, and even in the MRI cabin where we cannot take in other normal equipments, we have MRI compatible monitors. So it must have a good battery backup. That is what is more important about is. And if in ambulance or in air travel, there should be some UPS supply which can back up the monitor. We can't entirely depend on the battery.
Yeah. So basically, I think basic cardiac and vital signs monitoring is done throughout the period of the transport as best as we can. And that's where you were talking about the battery backup and everything. And yes, most of these newer monitors do have the capability for you to go back and check on, what exactly happened. If there was a desaturation or if there was an arrhythmia, you could probably look back into it, particularly if you're trying to audit your event if there is something untoward that happens. Yes, and I think that the question was, is TPR, BP, ECG monitoring done? And yes, that's what we are doing. All right, those are the questions I have on the chat section. But as I said, I do see that there are several groups or teams that are sitting in some of the units. So if any of them have a question, if you can raise your hand, I could probably see whether you can be unmuted alone and ask the question. If there are any questions. They say that if there are no questions, everything was clear or nothing was clear. So we'll assume the better one, but any questions from anyone else, any audience in any of our institutions? I do see that Apollo Noida, Kolkata, some other places, or Nashik, there are several people in the room. So if any of you have a question and want to stand up and get closer to the monitor and ask, that's perfectly fine. Okay, if there are no other questions, yes, there is a question.
This is Muthura from Apollo Cancer Institute.
Yes, go ahead, Muthura.
Sir, I would like to take something like, do we have a trained nurses, like usually the nurses in the ambulance are well trained for the critical patients to be transferred from one place to other places. Do we have a pool of nurses to transfer critically ill patient from Apollo to any other places? How do we go about? Do we arrange our nurses for the transport of ill patients from Apollo to other hospital if they go?
Okay. I can tell you what I know, and like others can pitch in and add. Usually, in at least in the Apollos in Chennai, the emergency department handles the transport of all critically ill patients. So they have trained personnel, doctors, nurses who accompany the patient, particularly for transfers between hospitals or between cities, whatever, like they are available for transport. So they are focused and trained on that. So the ICU or the critical care department in our units in Chennai, and I can't speak for all the Apollos, usually have been deferring this to the emergency department team. Pratima, you have any other thoughts on that?
Yes, sir. Actually, within Apollos, if we have an inter-hospital transfer, sometimes the nurse who is assigned for the patient, if there are any investigation and the patient is going to come back, they usually accompany. Otherwise, if it is going to be just the transfer of a referral or anything from one hospital to other, the emergency department takes care.
Yeah, I completely agree. Yeah, so we do send them for, specifically like PET scans and others where we have to move from one hospital to other. The same team that's in the ICU would go along with them. Mutram, if your question was, is there any focused training for them? I'm not sure. I don't think we've been specifically training them for the transport, but it's a really good idea, I think. And now that we have a simulation center in Chennai, I think it would be a great idea to use the simulation to train people on transporting critically ill.
So since I work in a cancer institute, we feel many of the patients, when the prognosis is poor, they would always like to take the patient. Maybe they live for another 6 months more, but there won't be any active treatment advised in that time. They are critically ill, but they need to be on continuous monitoring and shifted by land. Even some of our nurses travel 3 days. They drop the patient and come back. So I just wanted to know, is that any centrally available people for transfer? Some other people, like, they arrange their own ambulance from outside and go. So can we have some centralized format of Apollo critically ill patients to be getting shifted in a safe transfer way?
Yeah, I mean, the logistics have to be worked out. If they are centrally located, even for them to come and get familiar with the patient and then transport may not be easy. So having, at least the larger institutions in each of the cities, if they can have a team, that would probably help. It's a good thought. Thank you.
Thank you, sir.
So, Ram, if I could come in here, this is Ravi Mahajan.
Yes.
Can I, thank Ms. Muthram, just to raise that point. I think I've made a note of it. So certainly under the auspices of the Apollo Center of Excellence in Critical Care, we could devise a centralized course which can be delivered, using simulation centers. We'll discuss about it, but it's certainly a multi-professional sort of training would be welcome. So thank you for raising that. One of the outcomes of this the series of webinars has been that we get to learn as to where we need to focus. So thank you for drawing our attention to that.
Thank you. Yeah. Thank you, Ravi. I think that's a great idea. If the Apollo Center of Excellence could organize a structured program on this, I think it would be of great value. I probably did. Any other questions, anyone? Okay, thank you all. Thank you, Dr. Pratima. Thank you, Ms. Patel. Great presentation, very interactive from the audience. I really appreciate everyone's input. I think we will close the session. I do not see any further questions. So I guess we have finished ahead of time, but we'll close the session and look forward to many more interactive and interesting sessions from the Apollo Center of Excellence. Thank you.